Thank you, Mark, for the excellent presentation. Can we have some questions or something? What
Okay.
Mario suggests?
Okay, Prof. I think that we have got question on the chat box Q&A. Maybe that go back to you to ask the question for the first presenter, Prof.
Yeah, can you just read that question out?
Yes. We have now the question from the chat box. Maybe you will ask
Okay,
the question, Mr.
Can I start? So my question would be to Mark that that you found that there is a marked differences between rural and urban areas, right? In inpatient care as well as in the outpatient care. So is it related to access to the facility?
I'm sorry, sir, I didn't get the question.
My question is that you got differences between rural and urban areas, right? Rural and urban.
Yes. Yes, sir.
Is that related to the access of the services?
Yes, sir. I mentioned a while ago that there have been widespread efforts to improve healthcare service delivery in the country, but regional and socioeconomic disparities in the availability and accessibility of resources are still prominent. And there are also maldistribution of infrastructure and human resources across and within regions in the Philippines, and which are concentrated in Metro Manila, or the National Capital Region, and other major cities in the country.
So there is a large inequity in access to the facilities, right?
Yes, one of the reasons that scholars have pointed out is because of the devolution of healthcare services in the country, which has been in effect since 1991. And so these fragmented healthcare services depend, or rather the health services that are provided to the people depends on the continuity of the priorities of politicians, and it also depends on the economic capabilities of local government units.
These are the issues actually related to all the developing countries, and particularly the countries of South Asia. Yeah.
Yes.
And my another question is, I mean, you talk about the social pension for the elderly. Now, what kind of social protection system are in place in case of Philippines?
We have several, actually. For instance, we have privileges according to other Filipinos, like discounts in medicines, and but it varies. The benefits, privileges, according to them, varies by local government units. The richer ones, like mostly in Metro Manila, where financial businesses are centered, they tend to give more benefits to older people. Aside from that, older Filipinos or indigent older Filipinos receive a monthly social pension worth 500 pesos, or in US dollars, it's 10 US dollars. And of course, it's insufficient. It's almost a pittance, and because older people do not only use it for themselves, but also for their household needs.
Thank you.
Prof. Gus, excuse me. Actually, we have to finish all presenter.
Yeah.
So
Yeah,
we can
please
continue to Q&A.
Yeah, sure. But these are the quick questions. Then we will have larger questions. So let me call upon the second presenter, Ritu, who will be presenting on plague, public health, and public reaction towards plague prevention policies, a case study of colonial Punjab. It should be very interesting. And Ritu is from Jawaharlal Nehru University, New Delhi, India. Ritu, the floor is yours.
Thank you, sir. Very good afternoon, ladies and gentlemen. I'm Ritu from Jawaharlal Nehru University, and my today's presentation topic is on plague epidemic, in which I'm going to discuss and examine the plague to prevent the plague, what government take steps so that they can prevent the plague, and how people respond those policies. For this, I have taken the example of colonial Punjab. Why I have taken colonial Punjab as a case study? The reason is this. One reason is this: the Punjab was the one of the most badly affected from plague epidemic, and the another reason, in the colonial time period, Punjab was having an administrative value for British Empire, as the Shimla that was the part of Punjab province, and that was also a summer capital of British India that time period. And another, apart from this administrative value, Punjab was also having the value of military, because at that time, Punjab province that was on the border of British India. So there was the if we look at the a colonial state in which a province which is having an administrative value as well as the military value, in that state, when an epidemic is so severe, so my keen interest was to look in that how government decide to combat this epidemic. And one more reason, as the nature of the state was colonial, it was very clear that the states in their intention was to prevent their army, their European army, their European officers to save from the plague. So their priority was their empire, and in that at the same time period, when the general population they were dying from plague, how did they respond? And when government they decided to take some measures meant to control this epidemic, then there was the society diversion was so much high, ethnicity diversion was so much high. If we look at the social the composition of population, Hindu Muslim Sikh population was there, and the European population was very less, like very few number of population was there of European population. In that time, like in this diversion of society, it is very interesting to understand how these how like with their social custom, how these people respond these measures. So objective of my paper is to examine the spatial and temporal pattern of plague epidemic in Punjab, and also to examine the social composition of plague specific deaths, like who were those people who were badly affected and who were those people who were less affected from plague. Also to discuss the government policies and the response of public towards these policies. For this purpose, I have used archival data, and in this archival data, I used most of the sanitary reports, annual sanitary reports of Punjab government, and also I used the special reports which was represented by the plague commission of that time period, and to understand to examine the people reaction, to observe those reactions, I have gone through with some newspaper articles. The reason why I have used newspaper articles is the same reason, because sometimes officers they were purposely hide some people reactions, so that I gone through some newspaper articles also. To see the level of plague mortality in Punjab from 1890 to 1907, I drew this map from here. And in this map, we can see that in the initial year, plague was very severe in the initial years of the 20th century, and total 31.17 lakh people died over this period. And within the first decade of 20th century, more than 20 lakh people died from plague only. Like we can see that how severe and how dense intensity of plague epidemic in this in this decade. And also during the first decade, the plague was continuous very high, and this caused very high toll, death toll in Punjab. And in 1907, it crossed all limits, and more than 6 lakhs people died within 1 year from plague. Only just plague causes I'm telling, no, not other reason I'm in this thing. So plague was very, very severe in this province. And when I look at the pattern of plague in this area, plague used to comes like the plague cases used to increase in February month, and in March and April month it goes to like at peak, and after May it start decreasing. So March, April, and May, these were the months when plague was on its peak during the time period. And later on, in the later years, and when winter comes, plague cases almost negligible, but those cases are only negligible. Plague was never end in this area, and in next year, plague again comes and again causes so much disaster in this area. In this area, there are 3 types of plague: bubonic, pneumonic, and septic. And in Punjab, bubonic was the most common type of plague. More than 70% plague deaths were from bubonic plague. In rural and urban area, this is very interesting to understand the phenomena of plague in Punjab. Generally, in literature, it is shown in other countries that plague is an urban phenomena, but in Punjab, it's a rural phenomena. And all over these years, in the rural area, death rate was higher than the urban. Even in some years, like in 1903 and 1907 and 1915, plague was the death rate in rural area was double than in the urban area. And when it comes to understand the social composition of population, these categories are divided by the then administration, and like these are the ethnicity of Punjab society. So there are some categories. These were divided by those administration, and in this data we can see that the Muslim population, those were highly affected from plague epidemic. And other than Muslims, there were some caste, Ramdis and Chamar and Sweepers. These are the some caste which is scheduled caste, and these names are mentioned in the plague reports. So these are the people who were involved in low working. They were removing the corpse and other things. So they were the more vulnerable to the, and their exposure were higher to the disease. So they were most affected with this disease. And within this ethnic group, when we see the male and female death ratio, it can be visible that within each group, the female death rate were higher than male death rate in each group. The number is varying. The number is varying like that can be, but the pattern is the same. Like female were was affected to this disease, and there can be reason of the patriarchal society of this gender discrimination, which was much practiced even in that time period of Punjab. Female feticides were there, and the other gender discrimination was there. So that could be a reason that in almost in every section of society, female were most affected. And to see the detail of this male and female pattern, I have used the data for districts of Punjab, and in this data also it can be seen that there are few districts which were less affected, and on those districts which were more affected or less affected, even then, still the pattern is same. The female death rates were higher in all districts than their counterpart. And to examine, to compare this thing, I compared this data from another year, that is in 1907. In 1907 was the same, the year when plague was very, very, very severe. In this year, we can see when the pandemic is on its peak, so there is no social discrimination. Like pandemic, they are not discriminating people, but it's the society where the gender discrimination is there. So this is clearly visible that females were more vulnerable to disease. To examine the age pattern of plague mortality, I have compared it with other disease in Punjab. And in this graph, we can see that other disease, they used to formulate a U-shaped kind of graph where the children and the elders, they were much affected. But this is the line where the plague and death rate are showing, and we can see this thing that even when the children and the elders, they are the much affected from plague, but if we compare it with other disease, it is shown that plague did not discriminated age groups. It was like all groups, they were equally exposed to plague, and everyone like plague create very, very disaster in this area. To combat this epidemic, government formulated some committees. They also constituted Epidemiology Act in 1897, and for vaccination, they used the African anti-plague fluid vaccine. And other than this thing, this was the one in all India level. And to execute, they give some detailed described measures like isolation, segregation, evacuation, discussion, and disinfection, and also the eradication of threats, so that they can control the disease. And in this thing, we can, it is one more thing is clear, that their main focus was on those methods. Those were kind of imposing on people. Like they did not invest in public health. They did not invest in to make more hospitals here, to recruit more doctors. What they did, what was the already existing administrative staff, they just divide, they just give their duties, and they gave them more duties to combat this disease, but they didn't recruit more staff to control this area. After long, in after 1907, 1908, then they started take help of people, where the local Ved and doctors and Hakim, which are the Unani and Ayurvedic doctor, they start taking help from them so that they control this disease. Here is the detailed work of this medical staff. There are the hierarchy that they were keeping all data and the supervision of plague operation, including the inoculation operation and the other operation. This is the team of medical staffs. And the most important staff was the district administrative, because district administrative, they were responsible for the execution of these measurements. Also, they were responsible to release the fund, and where some pupils, they were opposing the measurements, they also used army and police so that they can control those areas, and they can impose forcefully coordinate those areas. They can they can vacate those villages so that they can control this pandemic. So in this sense, this is also visible that the government, they were the administration that were highly insensitive, and they were just trying to control the disease, they were not looking at the other factors of peoples, but they are what they are having facing at that time period. They did not even keep in mind if they forcefully implement the lockdown on people, their livelihood was losing. But the British government, they didn't have not done anything to ensure the livelihood of the people. And when it comes to the medical facilities was very less. Only 267 dispensaries was in 1898, and over the 43,000 people, there was only one dispensary. And for women, there was just 24, and it was till 1915. So it can be imagined a state, but a province which is so much important to a British Empire, and just 24 dispensaries were there. And the vaccination speed, that was also very slow. Just 7.7% population of the infected population only. The only 77% population was vaccinated till 1903. So it can be seen that the speed of vaccination was also very slow. And there was some incident when instead of plague vaccine, people was given the tetanus mixed vaccine, and within one family, 9 members of one family, they were died, and due to that reason, they were roads. People were like started suspecting government, and they were thinking like that government, these vaccines, they just want to kill the people. That's why they are killing people, because they just want to continue their colonial state. And also there was racial discrimination. There was discrimination between Europeans and Indians. When it comes to matter of Shimla, they focus on Shimla because it was their summer capital. When it comes to the other part of Punjab, they did not bother about that thing. And for people, it was their mindset that plague is a disease which belongs to poor class. So that purpose, there was so much restrictions on third class in a rail passenger. But if you are buying a second class ticket or the first class ticket, then they were not so much strict on those first class and second class passenger. And in a newspaper, the Tribune newspaper, they stir on this thing that do the plague disease see with what ticket you are purchasing. Is this a second class or the first class? And within India also, there were discrimination. When there were some plague camps, there were separate plague camps for Orthodox Hindu and the separate camps for the Muslim and rest Dalit people. And not only their camps were different, even the cook, they were separate for Orthodox Hindu and the other people. So this racial and ethnic and caste discrimination can be seen in government measures. And public response was very variant in this area. Most of the people initially, they opposed government policies. They opposed the segregation and the isolation. They preferred rather to die from plague instead of going to plague camps. And they also reject evacuation. They do not want to leave their house, leave their village. And because if they leave their house, there was many cases of theft also, because government was not ensuring what will happen if they leave their house, and what will happen to rest of their leaving behind their cattle, their other articles. This government was not taking the responsibility of their rest leaving a house. Also, government was not taking the responsibility of making more huts, more plague camps. They were just issuing the order that this village is an infected village and this must be evacuated. That's why people reject this evacuation. There were some. There were the reason of this oppose. Sometimes it was religious faith, like and there was a case when a Sayyid Muslim, they denied to leave their house, and they said that we are not covered, we are not kafir, we are not going to leave our house. And other sometimes they are taking it with their owner. They were thinking like that, if our women, they will be examined by another male person, that will be the violation of their honor. So their honor and the religious faith, they were counterpart of these with these measures. Also, due to the isolation, due to this this segregation, people, they were losing their livelihood. And when they were left and they left in their houses, there were fear of theft also. And the rumors play a very role important in this time period, because there were rumors that government they were evacuating these villages so that they can control. So the nature of colonial state was.
Ritu, your time is over. I mean, can you wrap up?
It's
Will
over
you
or
permit?
left 5 minutes, sir? Do I have
No.
5 minutes more?
No, 5 minutes will be too much. I mean, it is already 3:45.
Okay. Just I will take 1 minute only. Give me just 1 minute only. So people oppose these measures, and not only they oppose the measures, there were some section in the group in society, they criticize insufficient medical facilities and the racism and the insensitivity of administration. And other than this, they also decide to appeal from people also that they should cooperate with these measures. To cooperate with administration, people form some groups, some religious group came forward, and to they studied supplied medicines, and they carried work of these measures. So in my concluding remark, firstly, I would like to tell this is the pattern of plague epidemic, and so plague was very higher in this Punjab province. And when it comes to the on plague policies and people response, administration was very coercive and very insensitive when they were executing their measures, and people were discriminating on their ethnic identity, and that's why there were variation of people respond, and their response were varied how they pursued these measurements. Thank you.
Okay, thank you, Ritu, for your wonderful presentation. We will have the question and answer and discussion later. Let us first finish the presentation first. Next, I would like to invite the next presenter. Since Parul Puri is not here, so our fourth presenter is Zhonghui Zhang, who is from the National University, Canberra, Australia, and he will be presenting on poverty alleviation, improving equality in access to basic health services, and mortality decline in China. Zhonghui Zhang, the floor is yours.
Yes, okay. Let me get my PowerPoint file. So could you see me? So see my PowerPoint file?
Yeah, please, whatever you.
Right. Okay, that's good. And the sound is okay, right? Right. Colleagues and friends, it is great to have met you again at our conference. As you see, this is the joint paper. First, I want to acknowledge the contribution of my co-authors, and also because the paper has already been published, I will give you a very brief summary of that paper, especially its major conclusions. Let me start with two major reasons for conducting this study. In 2006, I published a paper in PDR. In that paper, I pointed out that China's recent economic reform not only generated rapid economic growth, but also led to many adverse impacts on healthcare, especially between 1978 and the early 21st century. Here are some of the adverse impacts on healthcare. First is the collapse of the old healthcare system. China's rural cooperative medical system coverage fell from 90% in 1976 to less than 5% in the early 1990s. Next is the decline of government share in health spending. It dropped from 36% in 1986 to 16% in 2000. The third one is the skyrocketing price of healthcare.
Excuse me,
If-
Dr. Zhao, do you have the PPT?
Sorry, you can't see it?
No, we
Oh,
can't.
oh, let me try to do it again, sorry.
You can just go to the share screen of the, yeah. Yeah,
How
yeah,
about
it is
now?
coming. It
Is that okay?
coming. Yeah.
Oh, I'm
Fine.
sorry for that. Okay.
Fine, please continue.
Just continue,
Yeah, please.
right.
Yeah, absolutely fine. Yeah.
Right, okay. And the next adverse impact is that there's skyrocketing price of healthcare. Before the year 2000, China had a period of major inflation. In some years, the inflation rate reached 25%. There are also an increase in the share of private health spending. It's increased from 22% in 1980 to 60% in 2000. And the last one is growing inequality. If we look at the Gini coefficient, it's increased from around 30 in 1980 to almost 50% in 2008. And earlier I mentioned I published a paper in 2006, and now 15 years past, we need to provide an update of recent development. The second major reason of conducting studies is that between the later 1980s and early 21st century, many East European countries and former Soviet republics experienced major social, political, and economic changes. During this period, their life expectancy had a slow increase or even declined. But this kind of change has not happened in China. Its life expectancy continued to improve and was higher than that for many countries with similar or higher per capita GDP. For example, if you look at this figure, there are two figures. In the horizontal line that gave you per capita GDP in US dollar, and the vertical line is life expectancy. In the first graphs, all countries, they have per capita GDP lower than China. Among those countries, there are only 4 countries have higher life expectancy, and the red dot is China. In the second figure, all countries have a higher per capita GDP than China, And there are about 30 countries have a lower life expectancy than China. Again, the red dot is China. So we want to find out how has China achieved this. We know that there are many factors contribute to the improvement of population health. In our study, we have focused on identifying major macro social economic determinants. And our study pointed out to 3 such determinants or factors. The first one, or the first macro determinant of population health is rapid economic growth. China experienced very rapid economic growth since 1978. From 78 to 2000, its GDP increased 32 times. Government revenue increased 23 times. Government health spending increased 63 times. All those that are after controlled inflation. When we look at government health spending, it has grown more rapidly since the early 21st century. The rapid economic growth first helped to improve the healthcare facilities. From 1978 to 2016, the number of hospitals in China increased 3 times, and the number of hospital beds increased 3.5 times. It also helped to improve the teaching and the training in medical science and healthcare. In 1986, there are 28,000 students graduated from medical college and university. It rose 24 times by 2016. In 1979 and the 1980s, China had only 89 students graduated with a master or PhD degree in this area. By 2016, the number rose to 66,000. All those trends directly lead to an increase in well-trained doctors and the medical technical personnel. The number of doctors grown more than 3 times between 1978 to 2016, and the medical technical professionals with a college or higher degree increased from 41% in 2003 to 72% in 2016. The rapid economic growth also lead to an increase in people's income and their health spending. From 1978 to 2016, per capita household income increased for more than 15 times. The share of private health spending also increased. The spending in household expenditure has grown from 4% in the mid-1980s and to 88% in the mid-2020s. The health spending grew faster than that of household income. This is related to the decrease of Andrew index, because people now having more money to spend on other things rather than food. So this is the macro determinant 1. The second macro determinant is the reestablishment of the nationwide health insurance system. In the early period of its reform, China's former health insurance system suffered a major setback, and this led to a larger increase in private health spending. The government made a great effort to rebuild 3 nationwide health insurance systems between 1998 and 2015. The 3 systems are Urban Employee Basic Medical Insurance Program, the second, New Rural Cooperative Medical System, And the third one is urban residents basic health, basic medical insurance program. All these three programs, they developed rapidly in the next 1 or 2 decades. The members of rural insurance system rose to 800 million by 2013, and those in the 2 urban insurance system increased to 744 million by 2016. The proportion of people participated in this insurance system reached a very high level. And also, the national reimbursement rate for listed medical treatment and medicines reached 8%. That's a very high level. And here in this table, I collect some results from the medical service survey. And those results, they are arranged by medical insurance system and the year. The first panel is urban employment insurance. The second one, urban residence insurance. And the third one, rural medical insurance. Because it's relatively complicated, I just mention the column and tell you what they inform us. If you look at column 2, this one, and it tells you the proportion of person time having taken the required inpatient treatment generally increased. Column 3 is tell you the proportion of claim reimbursed by insurance scheme increased. Column 3, reimbursement as a proportion of total claim increased. And column 4, the average reimbursement per claim increased. And if you look at column 5, that is the average out of pocket payment. That the trend in here not very clear. But if you look at the last 2 columns, column 6, average household income per household member increased, and also the proportion of out-of-pocket payment as the proportion of household income, they decreased. All this show you the health insurance indeed help to improve the availability and accessibility of health service. The macro determinant 3 is the poverty eradication effort. Poverty was widespread in China in 1978, when at that time, 97% of its rural population were impoverished, according to the 20 and 10 poverty line. Poor health is often closely related to poverty. Poverty is a main cause of poor health, and the poor health often result in poverty. China's recent improvement in population health could not be fully understood without taking into account its poverty alleviation effort. Since its reform, the Chinese government had made a great effort to fight poverty. And people living below the 20 and 10 poverty line fell from 770 million in 1978 to 661 million in 85, 462 million in 2000, 166 million in 2010. And recently, the government have announced that it has already left all poor people out of poverty by the end of 2020. To help the poor people, the Chinese government provided them not only income, but also support of other kinds.
Dr. Zhang, you have another 2 minutes to wrap up.
Right, okay. the major strategy of improving population health and fighting poverty is to provide medical financial assistance to the poor. Since the early 2000s, the Chinese government had developed and consolidated the three major schemes, that is, Rural Medical Assistance Scheme, Urban Medical Assistance Scheme, and the Rural File Guarantee Scheme. This scheme have two major purposes. First, to help poor people join the health insurance system, and second, to pay for their medical treatment directly. In 2014, the scheme helped 67 million people join the urban rural health insurance scheme, helped 24 million people paid their health spending directly. That is the indication to that paid by the health insurance scheme. And here I can give you two examples to see why poverty alleviation help improve health. The first example is that in the year 2013, in rural population, per capita annual income is more than 10,000 Chinese yuan. The enrollment rate of health insurance is 97%. In the rural low-income group, that's the poor people, and their annual income is only about 27% of average, but their enrollment of health insurance also 97%. There are also noticeable decrease in the proportion of patients who did not take required inpatient treatment because of financial difficulty. In rural population, it fell from 30% to 17%. In rural poor income group, it declined from 40 to 21%. The gap
Dr. Zhao, your
is
time
much
is
smaller.
up. And,
Yeah,
can you please wrap up?
I will finish. And to conclude it, I just want to mention 2 points. First, China's economic growth, reestablishment of its nationwide health insurance system, and the poverty eradication program are important macro-social economic determinant of mortality decline, because they help to lower the, people's vulnerability to health risk, increase the availability of health service and the insurance system, and improve their accessibility. And the second point, China has made great progress in improving mortality, but there are still major gaps in health care between China and many developed countries. China's health care system is also facing some major challenges. We have discussed those issues. People interested in those issues and these discussions can find more details in our paper published last December in Population and Development Review. Thank you.
Thank you, Dr. Zhao, for your elaborate, nice presentation. Now, let us open the floor for the questions, comments, and to all our presenters. The floor is open for the question and answers.
Okay.
Mario, please take care of the questions.
Thank you, Prof. Gus. We have one question for Ryan. Okay, the question runs, thank you for your presentation. Did you check the differences in healthcare utilization across the educational attainment of older people? Time is yours for Ryan.
Yes, thank you for that question. It's actually one of the interesting findings of the study that education did not appear to be a significant correlate of healthcare use. I do not have a concrete answer for this right now, but it is likely that the socioeconomic impact of education is not accurately captured in the study, since a large majority of the respondents have low levels of education. That is why others are less variation or heterogeneity in terms of education proposition. But yes, I do recognize that there is a need to tease the educational attainment more, tease out, to understand better the pattern and its to better understand its pattern and its association with healthcare use.
Okay, thank you, Ryan. For the all participation, please type your question on the chat box, and I will read all the question for this session. Prof. Gus, we don't have still any question from the chat box. We are still waiting. Maybe you can ask the question.
Okay, okay. Just one question for Ritu. Ritu, you are doing PhD, right? In CSRD. Who is the supervisor?
Chidanand Sinha.
Sinha sir.
Yes.
Do you know me?
Sorry, sir.
Okay. So you told somewhere that Muslims were more affected by plague, right? In the rural and so what could be the reason? Because Muslims were not doing the menial jobs at that point of time. I mean, SCs I can understand, but why Muslims? Is there any literature or any guess kind of thing?
Pardon, sir. I could not, like last line I just missed. Please repeat.
I mean, scheduled caste, one can understand that they were at that point of time doing the menial jobs, so all those kinds of things. So there is a high likelihood of being affected by the plague. But I mean, Muslims are not. But then what could be the probable reasons? I mean, so that Muslims were affected so badly at that point of time.
In case of Punjab, like when Islam came to India, so initially from scheduled caste, they were attracted to Islam as considering that in Islam there is no caste system. So most of Dalits, they converted their religion, and when they converted to Islam, even then their social structure and their social status and their other economic conditions remain same. So whether they are Hindu or the Muslims, but their social condition that didn't change. Even in Punjab area, there is a caste must be in a Sikh community. That Sikh community that was previously that was scheduled caste in Hindu religion. So now they are Sikh, but even then still their social structure that is lower than other Orthodox Hindu.
Okay, it is well taken. And another question is that I mean, you were mentioning that about that plague is primarily actually rural affair in case of Punjab, but elsewhere it is generally urban population, right?
In Punjab, basically in Punjab, the plague more prominent in canal irrigated area, and in those canal irrigated area that was for agricultural purpose. That's why it was like the canal irrigated area, and because now that was in canal irrigated area, so most of people they migrated to those areas, and that's why that caused the density of population, and also that caused the disaster also. So probably it could be possible. It's not a direct relation with that, but it can be a reason.
Yeah, maybe. Okay, thank you. And I have another question for Dr. Zhao. Just to, I mean, I will read your paper in publishing PDF, definitely. Just to let me, I mean, I just want to understand that why that the first health insurance system, which were introduced long back, that failed, and then the Chinese government has to introduce another kind of policy.
Right. China started to develop its health insurance system in the 1950s. And the old health system is based on different kind of social structure and economic structure. And for example, if you talk about the labor health insurance, they're largely paid by the company or the factory. And the old rural medical insurance or cooperative medical insurance is largely paid by the commune and the brigade. And then during the reform, especially in the early period of reform, and the old commune completely collapsed. And so there are no financial base for the old medical insurance system. And also there are a lot of factories and companies that are privatized. And there are also a lot of new companies, including joint ventures. And so the old payment system no longer works. And China have to, in addition to some other factor, the government have to develop a new system. And this is the major reason.
Okay, thank you. And I was just wondering that whether this, what about the social security scheme for the elderly in case of China? Whether is there any?
Sorry, state again.
Similar kind of thing and.
Social security what? Sorry, say it again.
Social security system for the elderly. How this health issues. If there is any kind of eventuality among the elderly, then how it is taken care of?
Right. Okay. And now China trying to develop a nationwide social security system. And you find in many places, both urban area, they already have old age security. Having said that, but it's also varied considerably. And recently, there also developed the financial assistance in the urban area and the rural area, particularly provide not only healthcare support, also the social support. Yeah. But there are some papers, and we read some paper as well, but the situation still vary quite a lot. Yeah.
Oh, thank you. I think there is a question for Ritu, right? Mario?
Yes, Prof. Gus, we have got one question for Ritu. I will read. From your analysis, what do you think are the lessons from the past that we can apply in addressing the current COVID-19 pandemic? Please answer. Time is yours, Ritu.
Thank you. Thank you for the question. And from my opinion, when I was working on this thing, and as we are already in the middle of a COVID pandemic, so these things were going on in my mind also. So from this, opinion, but I conclude that if the government, they keep in mind the livelihood, the question of livelihood, the people, they keep in that thing mind. So probably people will not oppose those measures. And another thing, if they will respect their social customs and other things. So and like the administration, they need to show some sensitivity towards their social customs and their beliefs, so that that can reduce the opposition from the side of people. Another thing, government should invest more and more in public health rather than imposing the restricted lockdown and the other restrictions on the people. If they will like, if people can have more medical facilities, so definitely there will be a disease burden will be less. So the government should invest more in public health. That's my opinion. Thank you.
Yeah, I noticed that there is a question for me. Should I answer it?
Okay, I will read for Zhongwei
Right.
the next question. Thank you, Ritu. Does the impact of socio-economic forces in improving population health in China differ by HOQ? Please answer.
Okay. Thank you for the question. And of course, the impact of socio-economic force is varied by urban and rural area. In fact, because our study is for a period of 4 decades, the force of social and economic influence or the force of economic development is also varied from time to time, varied by area. If you think about how the China's recent reform started, it actually started from rural area. And it started to have the responsibility contract systems. And that led to rapid economic growth in rural area first. And if you look at the trend in income during that period, rural people in rural area, income increased quicker. And then the reform also started in the urban area. And also when you look at the time when the Chinese government started to rebuild or redevelop its health insurance system, it started from the urban employee health insurance. That is in 1998. And then it started in rural area in 2003. And finally, it's also developed the urban residents health insurance system. That is in 2007. And because the system introduced at different time, clearly their impact on health is also started from different time. Having said that, it's also important to mention in many places, now the difference between urban and rural household registration or urban-rural hukou is disappearing. And increasingly, you'll find in many places, especially the more developed area, there are almost no urban and rural differences. And for some people, if you notice the figure, or if you look at our paper, and you find around the time 2015, if you add the urban and the rural health insurance member together, it's larger than the Chinese national population. Why is that? There are two reasons. One, in some place, you'll find the people who joined both insurance systems. And they, at hometown, they joined the rural health insurance, but because they're migrant, they also work in the city and they also join the system in urban area. That is the one reason. And this other reason is that, especially after 2015, in many places, the two systems start to merge together. So if you look at the figure for 2018, the number of people enrolled in rural health insurance declined considerably. And this is due to the change, due to the new reform change or new strategy has been introduced.
Okay, Dr. Zhou, the last one maybe for the question. Absolutely, poverty has declined, but what about the inequity? Has it increased in China? The question from Professor Saswata. Time is yours, Dr. Zhou.
Yeah, thank you for that question. And surely inequalities is still a major problem. And the Chinese government, they have done a lot. And this is particularly evident from the poverty eradication program and also from the medical financial assistance program. And to do that, the government has largely tried to give some help to the poor people. And but on the other hand, you also notice that in China, especially some area, the gap between rich and poor is still increasing. And but on the whole, for recent years, the Gini index seems stabilized.
Okay, we are still waiting for the participation who want to ask the question. Please write on the chat box. We are still have 5 minutes before we end the session. Okay, maybe we go back to Prof. Saswata.
Yeah,
Maybe
we
you will ask.
have some time. I just want to ask Ritu that at that point of time also there was a large resistance to the vaccination, right? As you have told. So, and nowadays India in the North Indian belt, I mean like Bihar, UP, all those places, we get the news there is a again resistance for this COVID-19 vaccination. So, does that mean that even after 100 or 120 years, pan-Indian culture, pan-Indian thinking has not been changed? What is your reaction, opinion?
I think there is a slightly changes in the mindset of people. If we compare with the plague epidemic and the nowadays, the mindset of people is slightly different than the time period, because the most important thing, the nature of the state that is changed. So now people are not, there are no kind of rumor that this government is vaccinated us just to control us, just to colonize us. So one aspect is the nature of state is changed, and another thing, the literacy rate that is also increased. So people are more forward to towards the health facilities. So as compared to past, the things are different. But if we see, like there were some example from Bihar that people started to worship the Corona Devi. It was the kind of example that in past time when people started worship of smallpox, they started consider that as a goddess. So, but now what's the difference? In past time, that was a common phenomena, but nowadays it's like an exception case. Not everyone is considering Corona as a goddess. I think the mindset that's changed, not completely, but far better than past time.
Very slowly, yeah. Okay, so you one question is there for Ryan. Can Mario please ask the question?
Thank you, Prof. The last question for Ryan from Geoffrey Abalos before we end the session. I understand that the survey data you use in your research is part of the comparative study that includes in Vietnam. Did you get the chance to compare the result of your study with the Vietnam data? Please, Ryan, time is yours.
Thank you very much, Kuya Jeff. Yes, the data that I used in this study was a part of a two-country comparative study on aging and health in the Philippines. However, I do not have access to the most updated data of the LSAV. So no, I did not get the chance to compare the results of my study with the Vietnam data.
Okay, thank you, Rance. I think our time is over, and thank you for all presenters has presents the article, and don't forget to see our session tomorrow. And thank you for all participation who has attended our session today. And don't forget, maybe we can take picture for the proof for this event.
Yes, please.
Okay, thank you. Okay, thank you. Go back to yours, Prof.
Yeah, thank you very much for this wonderful session. We have very nice papers presentation as well as wonderful discussions, and present as well as past. I mean, two separate dimensions we have actually covered. Thanks to all the presenters and all the participants. And after that, I hereby close the session. Thank you very much. Thank
Thank you.
you for Mario also assisting us.
Thank you very much.
Thank you.
Thank you.